Hello, everyone. My name is Althea Carless. I'm currently a clinical professional development nurse educator. I have an extensive, sorry. Oh, okay. Sorry. I have an extensive background in women's health and also oncology. Oncology has always been my first love as a nurse. When I started out as a med-surg, med-onc nurse, and oncology has been and still is my first love. So what I'm going to share with you today is a quality improvement project that was conducted at my institution, the title of it is Implementing the PLISSIT Sexual Health Methodology to Address Sexual Health Changes with Oncology Patients. A little introduction and background. A lot of time as standard of practice for the oncology nurses, they were able to address a cancerous patient, the physical aspect, their mental and emotional aspect. But however, where the gap was, the oncology nurses sparsely address sexual health changes that occurs with chemotherapy. They were very adept in addressing the primary side effects, the GI disturbances, the alopecia, the hair loss, but no one addressed or was afraid to broach the topic of sexual health changes. And so one day, I just got together with the nurses and I was like, we always talk about the primary side effects, but what about the sexual health changes that occur with these patients? Not because they have cancer, not because they're undergoing treatment and radiation, doesn't mean that their sex life ends. So we have to find a way where we can come together and address these changes so we can serve, do our patients some justice. And as you can see some of the stats, it shows that sexual dysfunction impacts 40 to 100% of oncology patients, especially those patients with reproductive cancers. And it also tends to be higher in the oncology population. So one of my purpose was, of course, to positively change the nurses' approach in addressing sexuality in the cancer population, and also to integrate a sexual assessment using the PLISSIT, which I will discuss later on, sexual health methodology into daily practice of the oncology nurses, and also changing their attitudes where they can come out of their comfort zone and be comfortable enough to address sexual health changes that can occur. So it's pretty lengthy, it's a mouthful, but when I got together and I sat, I formulated a clinical question, and it was for the infusion suite nurses at an outpatient infusion center. Will the implementation of the PLISSIT sexual health methodology compared to current practice improve oncology nurses' attitudes towards sexual health and documentation of patient sexual health concerns in 8 weeks? So this quality improvement project, it was a quasi-experimental design. The data was collected at a 62-chair outpatient infusion suite in Nassau County, Long Island, and my sample size comprised of 16 oncology nurses. There was a couple tools and theoretical framework that I utilized to frame this project. One was the sexual health care attitude questionnaire. And this was given pre and post implementation, and it was just a 17-item questionnaire that addressed the nurses' attitude towards discussing sexual health changes. I also designed a PLISSIT model, and what the PLISSIT model did, it was able to measure the nurse's performance and also verify documentation based on the 4 stages of the PLISSIT. The framework I used was the Iowa model, and with the Iowa model, it was able to improve patient outcome and satisfaction, and also improve the nurse's practice. The Albert Bandura's theory was based on the nurse achieving our highest level of self-efficacy. So when that was achieved, that was a boost for them, and they were able to step out of their comfort zone, tackle the issue of sexual health changes with the oncology population. So this is an example of my PLISSIT model. It's an evidence-based model, and it has 4 stages. The first one is the permission stage. So once the nurses were able to get through the permission stage, the other stages became easier. So for the permission stage, it's simply engaging the patient into the conversation. So for example, hey, hello, Mrs. Smith. It's not uncommon that sexual changes can happen with chemotherapy. Is this a good time to discuss sexual health changes? So now you're engaging the patient, you're setting the platform so the patient can say, some of the patients will say, well, sex is the last thing on my mind right now, I just want to get better. But even with that patient, as long as you start putting the bug in their ear to say, hey, this can happen, when it happens now, they can say, okay, I remember my nurse telling me that, yes, erectile dysfunction is real. Yes, I will have decreased libido. At times, my vagina will be dry. So at least they will know, so once they're educated on that, then they will know how to proceed because the information now was given to them. The limited information is the nurse giving the patient, because it's an overwhelming experience. I was on both ends of the spectrum when my dad, may he so rest in peace, had prostate cancer. And so I know I can empathize. I was on both ends as the caregiver and also the nurse administering care. So I never remember someone actually discussing sexual health changes with my dad. And he was a little older than my mom, of course. So at the time, I didn't know, but now I know. And I'm pretty sure with prostate, of course, he had erectile dysfunction. He had decreased libido, but for him, no one educated him. So he probably was like, I'm just gonna go with the motions and intimacy, because now I speak to my mom about it and she's open. The intimacy was gone, and it was just so unfortunate because he wasn't educated on that. So the limited information, you're just giving them enough. You're letting them know, yes, this can happen, so at least they know. And then the third stage is the specific suggestion. So depending on what their problem is, if they have a problem or what is to come, they know that they know, okay, my nurse already told me that I'm going to experience this. So if they are experiencing, for example, the woman who's experiencing a vaginal dryness, the nurse can say a water-based lubricant can help with the vaginal dryness. So you won't have to suffer the pain of painful intercourse, because dry sex is painful. So at least she knows that she have her options. She can use a water-based lubricant. For the woman who's undergoing radiation for cervical cancer, cervical stenosis is real. It happens. So a vaginal dilator, a lot of the older women will frown upon it when I say vaginal, what? Like, vaginal dilator. But once you tell them how to use a dilator, the effectiveness of the dilator, they're open to using a vaginal dilator. And then, of course, the intensive therapy portion, when all 3 stages has failed or is ineffective, then with the intensive therapy, we can make referrals out. So they could be referral to sex counseling or a sexual therapist, which can further aid them with their sexual health changes. These were the results from the data that was collected, and as you can see in the permission, the first stage, the engagement, 72.8%. The limited information, we have 61.7%, and specific suggestions. Intensive therapy was 0 because none of our patients, we had to refer them out. And this is from an 81 chart audit that was conducted by myself. And this is a visual of the data, a better visual. So I have permission, as you can see, where when I audited the charts, when the nurse went from permission, which is the first stage, as I mentioned, engaging, and you can see the results of using the PLISSIT, that it was influential. Then from the questionnaire, the questionnaire was divided into 4 subscales, and I'm going to give you the bar graph. So as you can see, pre-implementation from the first subscale, it was a little, what's that? About 2, and then after the PLISSIT, it went up at least 2.5, and you can see it from the other subscale also, and you can see that in fact, using the PLISSIT model was indeed influential. Some of the implications: utilizing the PLISSIT sexual health methodology has a potential, of course, to improve nurses' confidence. And in my quality improvement study, it was indeed influential for the nurses. And of course, further studies can evaluate the efficacy of the training programs. Some of the limitation that I encountered was, it was a small sample size. I had 16 oncology nurses. The time frame of the project, it was about 8 to 9 weeks. Of course, is the nurses' availability. At the time of the study, it was summertime, so most of the nurses had PTO. They were on vacation. And for my conclusion, it is recommended that oncology nurses participate in services where the utilization of the PLISSIT or any other sexual health methodology is encouraged. We have so many evidence-based methodology that can be utilized to get nurses out of their comfort zone, or any healthcare providers where they can address sexual health changes. We have one called the BETTER model. We have one called the ALARM model. The topic of sexual health can be uncomfortable. However, when we're dealing with the oncology population, the patient needs to know. It's a must, and that's something that I really don't compromise with, because I really don't think we're really doing justice for our patients if we are not educating them on sexual health changes. And doing so, we can use different methodology, and with using the methodology, we can adapt. Nurses can be more adept in the skill, and it can help to mitigate the taboo or the awkwardness that surrounds the topic. These are my references. I also have a QR code for a more detailed picture of the PLISSIT and also the questionnaire that was used. And I also like to take my time out to acknowledge the MP of Color for giving me the platform where I can disseminate the findings of my work. A lot of stakeholders were involved, and also my infusion suite nurses. And I just want to say thank you, thank you, thank you. Any questions? Go ahead.
It's not like the actual providers who are likely following those patients for surveillance, having these conversations or having an interest in what you were doing there.
Yes, my providers, especially the advanced, like my NPs and also my PAs. Where I work, each patient is assigned a nurse navigator. So the nurse navigator is their resource person. Or we try to enroll our patients in survivorship. So the survivorship is also that support that they get from someone who, or like them, somebody's experiencing the same thing. So we're providers, especially our MPs, especially our MPs, I have to say that with our MPs and their PAs, they were very good at making sure that our patients were seeing their navigator, the resources were there for them. But also I have to give a lot to my nurses, because we even if the patients didn't, we made sure that they did. So we call the provider and say, hey, so-and-so needs to be buddy up with a navigator, or a survivorship. So the resources were there for the patient. For women who, in their reproductive years, the provider would recommend harvesting their eggs. Insurance, for the most part, pay a portion of that also, where you could just harvest your eggs. So when it's time for you, when your treatment is over, and it's time for you now that you want to conceive, now you have your eggs in the egg bank and you can proceed with that. So the providers were very versed. It's something new, and you will get pushback for it, but I just let that just roll off my back, because my patient, it's an advocacy, just advocating for your patient so they don't feel alone. Because no one wants to be diagnosed with cancer. And it's so overwhelming. The first time, the visit, it's so overwhelming. So as nurses, frontliners, we are the driving force of patient-centered care. Yeah, the doctor will come in and extra, but we're the ones who spend most of our time with our patients. So thank you for your question. Anyone else? Time? Done. Thank you.